Dear colleagues, ladies and gentlemen, welcome to this edition of the View from the Thoraxcenter for Radcliffe Cardiology. This time we are wrapping up the late-breaking clinical trials of the ESC 2022 meeting in Barcelona. My name is Nicolas from Mieghem, and as always, I'll be doing this wrap-up together with my good friend and colleague Joost Daemen. Joost, one of the biggest trials that I was looking forward to was the Revived trial. What was that all about?
Yeah, so Revive BCIS2 was one of the 17 trials presented at ESC that were simultaneously published in the New England, which I think attests to the quality of the ESC this year. So the Revive trial was a multi-center randomized controlled trial from the UK to evaluate whether PCI plus optimal medical therapy was superior to optimal medical therapy alone in reducing the combined endpoint of all-cause death and repeat hospitalization for heart failure in patients with ischemic cardiomyopathy. So the trial at the end randomized 700 patients with a mean ejection fraction of around 27%, 40% of diabetes, mean age 70, but of interest, a NIA class of 1 to 2 in the vast majority of patients, and interestingly, 70% of the patients had no angina. So these patients again needed to have multivessel coronary artery disease with viability on ischemia testing. And in this case, in the PCR arm, underwent 2 vessel PCI on average. And what the trial showed is that PCI appeared to be safe. So that was, I think, the first takeaway from this trial. So no excess in per-procedural or MI, I should say, within the first 30 days. However, at 2 years, event curves for the primary endpoint were overlapping. So not showing any benefit in the revascularization arm as compared to the OMT arm alone. However, the KCCQ scores that were evaluated at 1 and 2 year were superior at 1 year in the PCI arm. However, the effect mitigated at 2 years, a finding I think that should be attributed to the fact that most patients in the OMT arm with complaints actually underwent revascularization in the 2nd year, so that was around 10%. So in conclusion, I think an important, well-performed trial with also some limitations I think that deserve to be mentioned. There was no link between the area of ischemia and the final area that got revascularized. And finally, and I think that is my key criticism to this trial, it was a trial that enrolled 700 patients in 40 sites in 8 years. So that's approximately two patients per site per year. And with that number, that makes me wonder whether there was a huge selection bias in this trial and that patients with more severe coronary artery disease, irrespective of symptoms and viability, either underwent routine PCI or CABG to hopefully improve their symptoms and prognosis. So yeah, that's my take on this trial.
Yeah, well, so I think I agree with you with your summary, but somehow I struggle with the interpretation and with the adoption of this trial in my practice because, as you mentioned, only 2 patients per site per year. Where were all the other patients then? Exactly. So this is a highly selected patient population to begin with. But then if you look at Stitch, for instance, the benefit of revascularization with CABG only occurred at 10 years, not at 5 years. Absolutely. So let alone at 2 years. So I think it's a little bit too early. That said, you already mentioned that there was more revascularization, unplanned revascularization done in the control arm, so 10% versus 2%. But I think the main issue with this trial is that 2/3 to more than 70% of the patients were asymptomatic. Absolutely. So they had no angina and they were in New York Heart Class 1 or 2, but 1 or 2, that is in an ischemic cardiomyopathy population with an ejection fraction of around 30%. I mean, why were they being treated? Mm-hmm. There was just no reason for treatment. At the end of the day, we saw improvements in the quality of life of the patients in both treatment arms, so both in the control arm, but definitely in the PCI arm and more significantly in the PCI arm. And these improvements were quite significant with more than 10% points in terms of KCCQ. So that was quite important. So I think will this trial readdress the guidelines? I don't think so. Otherwise, the only thing that we now can learn, that we can take away from this trial is that, when patients with an ischemic cardiomyopathy and you're thinking about revascularization for multivessel disease, you no longer only should consider CABG. Now we also have some data to support multivessel PCI. All right, the FRAME AMI trial.
Yeah, so FRAME AMI was another trial I was really looking out for, a multi-center randomized controlled trial from South Korea to compare clinical outcomes following either FFR or angio-guided PCI of non-infarct related arteries in patients presenting with AMI. So of importance, revascularization of the non-infarct related artery was guided by FFR, obviously in the FFR arm, however was strongly recommended in the angio-guided arm in case the diameter stenosis was above 50%. So that's because of a preview I mentioned. It depends a little bit on how aggressive the operators in this trial will be. Well, that was the answer that was clearly presented by the investigators. But then importantly, the trial aimed to enroll 1,300 patients, but then during COVID, the DSMB recommended to stop, to halt enrollment early at the end of 2020, and at that time the trial had enrolled 562 patients. So actually the presentation of this trial was based on on an incomplete trial, so to say. However, all patients were nicely followed, and what appeared that on a median of 3.5 years, there was a significant reduction in the primary endpoint being cardiovascular death, MI, or repeat revascularization in patients that underwent FFR-guided PCI as compared to those who had angio-guided PCI, mainly due to differences in death and MI, and also partly because of a significant reduction in per-procedure MI, which at the end accounted for half of the MI benefit in the FFR-guided arm, simply because 40% less PCI was performed. So to summarize, to me, one of the more interesting trials from an interventional perspective of ESC, however, also again a trial that is likely not going to change the guidelines. I mean, it was a trial that at the end was underpowered simply because of early termination of enrollment. It was prematurely discontinued, and that is one thing I didn't mention yet. AMI was including both ST segment elevation as well as non-ST segment elevation, whereas I think most of us, this question is mostly relevant in the STEMIs, whereas in non-STEMIs a complete revasc has been up until recently perhaps more promoted.
Well, at the same time, we will learn more next year on the issue of multivessel PCI in patients with STEMI or non-STEMI, obviously in BioVasc.
Absolutely.
Yeah. All right. Next.
Then the PREFFIR trial, so talking about non-culprit lesions in patients presenting with STEMI, so that was also the topic of the PREFFIR trial, a prospective study, again from the UK, studying the potential benefit of a PET-CT within 3 weeks after an acute MI to study the presence of hot plaques, so to say, in patients post-MI. So these are mostly, of course, plaques with a diameter stenosis below 50%, so those that were left alone during the index procedure. But what appeared is if you do a PET-CT within 2 to 3 weeks post-MI, you see that 2/3 of patients yet have hot plaques, as determined by a sodium fluoride PET marker. However, if you follow these patients up until a median follow-up of 5 years, there was no significant differences in event rates between those patients with hot plaques as compared to those who didn't have these hot plaques. So also a trial that would likely not change our practice. PET-CT is a very costly examination. It will add, I think if I understood correctly, almost 10 millisieverts of radiation to the patient. And given those trial results, I think is not something that at present we should routinely recommend to our patients post-MI.
Yeah, and you know, to add to that, I think these unstable plaques, they remain a clinical conundrum. And do we have to respond to it, yes or no? But one thing is for sure, we don't need to do a PET scan to look for that.
That's for sure.
I think another last study on clinical judgment after PCI was the POST-PCI trial, another South Korean study?
Another South Korean study, again New England, multi-center randomized South Korean trial that enrolled or actually randomized 1,700 patients to either routine functional testing after high-risk PCI at 1 year versus standard of care without this functional ischemia testing. Patients were followed for a primary endpoint of any death, repeat MI, or hospitalization for unstable angina at 2 years. What this trial enrolled were patients that underwent high-risk procedures, so a lot of bifurcation, stenting, multivessel disease, almost 40% diabetes. But then would appear that the primary endpoint, no significant difference in the occurrence of the primary endpoint at 2 years, so almost overlapping event curve. So with that, the trial concluded no place for routine functional ischemia testing 1 year after a PCI for a high-risk PCI, so to say.
Yeah, I think this is an important message because it will streamline but also simplify the follow-up of patients after a PCI. Because in a lot of countries, there is still this practice of repeating stress echoes or exercise testing on an annual basis or even more often after a PCI. Well, there definitely is no scientific background to support that.
I agree, and perhaps even stronger. I really had a little bit of difficulties in understanding the rationale of this trial in 2022. I mean, who is still in larger, specifically academic institutions performing routine functional testings? It's actually against the guidelines. It's very clearly stated in the guidelines that routine functional testing should not be pursued. That said, I agree with you. It's still frequent in many sites, and this trial finally provides some perhaps strong evidence on the fact that this simply should not be done. Second, yeah, the statistics of this trial are perhaps a discussion per se. So you randomize the patient at the time of the procedure, but then the difference in treatment strategy only starts to arise at 1 year, whereas all events between baseline, time of randomization, and 2 years were included. So I think that is something that at least I will need to find some time to talk to a statistician about the validity of this. But that's just on a small side note. Pharmacotherapy. So ESC was obviously a big cardiology conference with a lot of focus on pharmacotherapy, and there was a substantial amount of trials focused on drug therapy. And maybe the first, Nicolas, DELIVER.
Yeah, so DELIVER is in the context of heart failure, but more specifically HFpEF with preserved ejection fraction or only mildly reduced ejection fraction. More than 6,000 patients were enrolled in DELIVER. Median follow-up was 2.3 years. The primary endpoint was death or worsening heart failure, and definitely in favor of the patients who were randomized to Dapagliflozin. And that is a very important confirmation of what signals we already had in the past, that we may have found a therapy, medical therapy for HFpEF patients. And I think that is really something that we now need to acknowledge, because not only did we have an improvement in the primary endpoint in favor of DAPA, but also if you look at other hard endpoints like cardiovascular death and important endpoints like heart failure, hospitalizations, everything was in favor of SGLT2 inhibition. This trial was published in the New England. There was also a large meta-analysis published in parallel in the Lancet. I think we have to conclude that SGLT2 inhibitors should be foundational therapy in all heart failure patients, regardless of ejection fraction.
Yeah, no, there's nothing I can add to that. I mean, again, New England, I think 10 or 15 sub-papers almost published simultaneously. I think that attests at least to the interest this trial got at ESC and rightfully.
Yeah. Okay, so we stay in the heart failure context, and then there is this ADVOR trial. ADVOR trial, quite an intriguing trial. It was led by Wilfried Mulles. I did part of my residency training in Leuven together with Wilfried, so I know that he has built an impressive career in heart failure, and he has a tendency to think out of the box, but also try to implement clinically relevant strategies, and that is exactly what he did. This is a Belgian study that evaluates the use of acetazolamide, a very simple medical therapy, a diuretic, in combination with loop diuretics in patients with decompensated heart failure. 519 patients were enrolled in the study, and they had at least one sign of volume overload. But mind you, they were admitted with acute heart failure, and the signals of volume overload were either edema, pedal edema, pleural effusions, or ascites. And they also had to have elevated natriuretic peptide levels. So they were then randomized to either standard of care, and the standard of care was defined as you double the maintenance dose of loop diuretics and you give it intravenously. And then the treatment arm was, or the study arm was 500 milligrams of acetazolamide intravenously in parallel, so next to this furosemide or bumetanide IV infusion. Well, it turned out their primary endpoint was decongestion at day 3. And then I said, whoa, decongestion at day 3, what kind of an endpoint is that? Well, it is, dare I say, a soft endpoint, but still they managed to hit the New England, and it is a little bit reminiscent to the DOSE trial, which was another study published in the New England 10 years ago on 300 patients, where they evaluated high dose versus low dose and continuous versus intermittent dosing of diuretics with an endpoint that was defined as the global assessment of symptoms by patients as primary endpoint. So again, a little bit of a funky endpoint, not the hard clinical endpoints, but still, if you look at this decongestion endpoint, acetazolamide resulted at 3 days in decongestion in 42% versus only in 30% of the patients in the control arm. And at discharge, it was 79% versus 62%. So basically what this trial tells us is that you can use various diuretics together in order to optimize your diuretic response. But at the end of the day, there was no impact in clinical outcomes at 3 months. So no difference in death or rehospitalization. So, you know, I think it's a very nicely done study, but, you know, I would pull the brakes a little bit on the enthusiasm. Yeah, and by the way, another important aspect was that none of the patients were allowed to get SGLT2 inhibitors. And obviously, SGLT2 inhibitors also operate at the level of the proximal proximal tubules of the kidneys. So yeah, it is. We need to keep everything in perspective, but very, very nicely done by our Belgian colleague.
Yeah. Any insights into electrolyte disturbances with this additional?
Yes, so they definitely looked at all kinds of secondary endpoints. So when you use Diamox, then you might expect metabolic acidosis. Well, it was not there. You also might expect more hyponatremia or hypokalemia, but that was not apparent in this study. So hardly any side effects. So I think definitely for acute heart failure patients, I think we should no longer just give loop diuretics intravenously, but also add Diamox or acetazolamide.
Yep.
The REDUCE-IT trial. I mentioned in our preview that Deepak Bhatt would come back with another main presentation based on the REDUCE-IT trial. The REDUCE-IT itself was evaluating icosapentadyl ethyl, which is a purified ethyl ester of one of the omega-3 fatty acids. Basically, the main findings of the trial were already presented and published in 2019. At this ESC meeting, they focused on the subgroup analysis, and they were looking at the impact of such therapy on top of high-dose statins and so on in terms of myocardial infarctions, the occurrence of STEMIs and non-STEMIs. And it turned out that these omega-3 fatty acids, these purified ethyl esters, indeed made a difference, and patients did better if they received these drugs. I'm very much in favor because there isn't hardly any side effect related to these therapies. And I think once you get these purified esters over the counter, that might be a worthwhile add-on to what we're giving to patients with coronary artery disease.
Yeah. Invictus?
Invictus is an interesting study because now we're moving to the patients with rheumatic atrial fibrillation and the value of non-vitamin K oral anticoagulant drugs. So in Invictus, rivaroxaban was compared to vitamin K antagonists in patients with proven rheumatic heart disease. It was a large trial, more than 4,500 patients from areas where rheumatic heart disease is still endemic, and we're talking about Africa, Asia, and South America. Mean age of the patients was only 50 years old, and 72% were women. The median follow-up was 3 years. The primary endpoint was a composite of stroke, embolisms, myocardial infarction, and death. And it was a little bit surprising maybe that vitamin K prevailed. It turned out to be superior than rivaroxaban, and the bleeding rates were very low in both treatment arms. So how do we need to interpret this? Because obviously from the pivotal studies on non-valvular atrial fibrillation, we know that NOACs are at least as good, if not superior, to vitamin K antagonists in terms of net adverse clinical events, and definitely also in terms of bleeding. Well, we have to acknowledge that there has been a precedent. We also know that in patients with mechanical heart valves, non-vitamin K antagonists are inferior, are not as good as vitamin K antagonists. We know that from the REALIGN study a decade ago published in the New England Journal. But that doesn't mean that NOACs cannot be used in patients with valvular heart disease, because we have the envisaged TAVI-AF and the Atlantis trial that have clearly shown that it is safe to use non-vitamin K antagonists in patients after a bioprosthesis.
Yeah, I agree. I think it's interesting, specifically already given the bad press of and the labeling, at least in Europe, for rivaroxaban post-aortic valve treatment. This trial will for sure not help to settle that issue. So yeah.
Well, but I think we have to become wiser. We should know in what indication a NOAC is a very potent drug, and it's not in patients with rheumatic heart disease, and it's not in patients with mechanical heart valves.
No, I agree. So more on antiplatelets was presented in the findings of the Pacific AMI trial. So this was a multi-center randomized controlled dose-finding trial, a phase 2 trial actually, that was online, also published by Sunil Rao in Circulation. A phase 2 trial in which patients were randomized post-MI to 3 doses of asundexian, a factor 11A inhibitor, or placebo. Of interest, so patients were randomized on top of routine therapy. I thought it was aspirin clopidogrel given the add-on, but what appeared is that almost 80% had ticagrelor or prasugrel as their routine therapy post-MI. So an interesting observation, but then what appeared is when these patients were followed, is that there was a numerical increase in bleeding with higher doses of asundexian. However, on average, there was no significantly different bleeding risk in patients receiving asundexian versus placebo. A bit of perhaps counterintuitively. However, if we looked at the ischemic events, also there no effect at all of asundexian as compared to placebo. Also something that perhaps you wouldn't have expected. With respect to the bleeding, there has been the Pacific AF trial. I don't know if that's something you recall, published in Lancet in April, in which we already found that with asundexian, you have a somewhat lower bleeding risk as compared to apixaban. So the low bleeding with this drug is something that is clear. But conversely, there was no ischemic benefit by adding this drug. So I think the investigators will have a hard time in designing a phase 3 trial with these findings.
Honestly, I'm quite relieved, because I'm a little bit hesitant to keep on adding other anti-thrombotic therapies on top of the existing treatment regimens that we're using, because bleeding really remains an issue in current practice. So if you can replace one drug for another, I would be okay with that. But if you keep on adding, I'm not sure whether that will help our patients. And by the way, we're treating more and more elderly patients, so they have more and more higher bleeding, more and more patients with a high bleeding risk. I think we have to be very careful and about that. Yeah.
A more positive trial was SECURE, and SECURE is a very interesting trial that included almost 2,500 patients post-MI that were followed for 3 years and were actually randomized to either receive a polypill containing aspirin, statin, and ramipril versus standard of care therapy. And what this trial actually showed is that if you look at the primary combined endpoint of CV death, MI, or urgent revasc, there was a 25% reduction in the primary endpoint in patients on the polypill as compared to those not receiving the polypill. So this, I think, clearly attests to the fact that with a polypill, adherence is simply better and a greater effect is to be expected. This is in line with the hypertension literature, in which we're more and more inclined to switch to combination therapies, even now per most recent guidelines. And this could add to that concept for patients with patients post-MI or even those with heart failure.
What is disappointing, obviously, is that we do see a 25% reduction in patients who receive the polypill, because that means that there remains an issue of compliance with the patient, but also of inertia with treating physicians. Not always treating physicians are willing to prescribe the necessary medication. And on top of that, what is reassuring is that we don't see an excess in side effects. Yeah. So this is really a safe therapy. So you need to go for high intensity statins, add an ACE inhibitor and an aspirin in these patients post-MI. I think that should be the standard of care. And we may need to do quality surveillance in order to make sure that our patients are receiving optimal therapy. So let's switch to structural heart. There were a couple of studies that we previewed. One was the COAPT-PAS. The COAPT-PAS was a post-approval study in the United States. It was a program that was initiated after the COAPT trial. The COAPT trial obviously was evaluating the MitraClip in patients with secondary MR, in heart failure patients basically, and that was a positive trial in favor of MitraClip, where we had significantly less or fewer hospitalizations in the treatment arm. In this COAPT-PAS study program, 5,000 patients with secondary MR were enrolled. And what they saw was that patients by no means had the same guideline-directed medical therapy on board. So the rigor that was used in the COAPT trial, in the randomized trial, to make sure that patients were on guideline-directed therapy was not maintained in this post-approval program, but still, patients had an enormous improvement in their quality of life, because a KCCQ improvement of more than 20 points, that is huge. That is really a very important, not a moderate, but a very large improvement in quality of life. And also, they noted durable improvements in mitral regurgitation at faster procedure times relative to what was known from the COAPT trial. So I think my takeaway is we need to be a little bit cautious with over-interpreting the COAPT trial. The COAPT trial was one randomized controlled trial. It was not duplicated by anything else. So now we see in all the guidelines that they just copy-pasting the inclusion-exclusion criteria, and also are very instructive and demanding guideline-directed medical therapy. But we have to be realistic. Guideline-directed medical therapy is important, but sometimes, or dare I say oftentimes, in clinical practice, it's very difficult to maintain our patients on these therapies. And it would be a pity if we deny our patients then a MitraClip therapy or a TEER therapy, because the patients will do much better. Yeah. So that's why a little bit of realism in the interpretation of everything that is related to TEER treatment might be good. And I think we may need to soften the criteria to treat our patients with TEER.
Well, were there any predictors? Because as you mentioned, I mean, COAPT was perhaps too restrictive. MITRA-FR is a bit different. This TVT registry, obviously there were no restrictions. 5,000 patients, any data on potential predictors of effect, or any new insights on patients that actually, as a category, did not fare well?
Well, this study was not published yet. It's not published yet. So based on the presentation that I saw live at ESC, I did not see any remarkable predictors that might be of guidance for our current practice. No, but definitely something that we need to follow up. And my bet is that we will see the initiation of new, larger randomized controlled trials to further study the use of TEER in these patients.
Yep.
So we also mentioned this study from Australia where they evaluated artificial intelligence in patients with aortic stenosis. And indeed, what happened was that they created a neural network based on artificial intelligence, and that network that evaluated all kind of parameters from echo studies, and they analyzed, they inserted in their network more than 1 million studies, echo studies derived from more than 600 patients. So an enormous data set. And basically they were successful in identifying the patients with aortic stenosis who would have a poor outcome. I think this is the beginning of a new era in terms of diagnosis of aortic stenosis, and definitely it can help on how we need to interpret echo as a community and how we can bring echo data to our clinic.
Yeah, a first step, I think, in a very important topic. A well-performed study in an enormous amount of subjects or tests, I should say, and I think that attests to the quality of the trial. Yeah. But also, as predicted a little bit, something that needs to be tested now prospectively to actually learn about the potential value and how to implement this.
Yeah, I agree. Further validation is definitely required. So we stick in the era of 2022, and this is where we want to use our smartphones in the diagnosis of, for instance, atrial fibrillation. And in the eBrave AF trial, more than 5,000 elderly patients, so above 65 years old, who had a smartwatch, were eligible for this study. And then they were randomized to either smartphone AF screening or conventional AF screening. And in the treatment arm, in the study arm, patients were evaluating whether they had atrial fibrillation using their smartphone twice a day for 2 weeks and then twice a week thereafter. Turned out that the treatment arm, in the arm that was using the smartphone screening tool, the number of newly diagnosed atrial fibrillation was double, and it resulted also in the initiation of oral anticoagulant drug therapy. I think this illustrates and attests to the fact that digital screening definitely has a place in our current practice and seems superior to detect atrial fibrillation than our old school conventional AF screening based on symptoms. So I think we need to get better, and we need to find ways to install these programs involving smartphones and other devices in our practice.
Yeah, I think this again is another beautiful example on how medical technologies, wearables, AI are going to change the way we diagnose patients, we treat patients, we monitor patients. Look at the Monitor HF program with the CardioMEMS. I mean, there's so many things up and going at the moment. It's truly fascinating.
Yeah. What else do we have?
So I think that's it, Nicolas, for today. I think we covered a lot of trials. It was a tremendously interesting meeting. I enjoyed being on site again and catch up with a lot of colleagues and friends. And yeah, so far our ESC wrap up for 2022.
Yeah, an intriguing meeting, I agree with that. And we're now gearing up for TCT that is coming up 2 weeks from now. So expect another preview in the forthcoming days. We hope you enjoyed this wrap up, and we'll see you later. Thank you very much.
Bye-bye.